Okay, so let's talk about contingency management in MST. What is CM? It's a researched behavioral approach to substance use treatment, and it addresses the correlates of substance use described in the causal model. This is what makes contingency management a great complement to MST in the treatment of substance use in youth. CM is one of the most extensively researched and best validated treatments in the field of substance use. Additionally, MST has solid evidence on its effectiveness in treating substance use. It is touted as effective treatment for substance use by the United Nations Office on Drugs and Crime and NIDA, among others. So there are 4 key components to contingency management. And while I list these out, I want you to listen and I want you to think about how similar these sound to how we approach substance use in standard MST. Okay, so the first component is the use of an ABC assessment of the substance use. So this is the antecedent, the behavior, and the consequences. It includes identifying triggers. Family drug management planning, including drug refusal skills, is the second component of CM. The third component is the objective monitoring through drug screens and breast scans. And the fourth component is a point and level reward system. So when you hear that, I'm sure that you're considering a lot of the things we already do, like sequencing, drug testing, which is already a part of what we do in MST to get those good objective results. And the FDMP and the refusal skills is an example of behavior planning, supervision planning, refusal skills that we develop with our adolescents. And the point and level reward system also speaks to the behavior contract that we currently do in MST. So lots of similarities. So all interventions in the CM manual are available to MST teams for use with youth as indicated. So as always, what we do in MST is driven by our analytic process, discussed within MST supervision and within consultation, so we can come to a consensus about what makes the most sense. To administer the full CM protocol, we have to use all 4 of the key components with a given youth in a highly structured way. And so the full CM protocol is extremely intensive and not always necessary, and sometimes we wouldn't want to take on that full protocol if it isn't necessary, because it is very difficult to implement and requires a lot of higher functioning on the part of the caregiver. So the criteria for considering using full CM protocol in MST is the substance use would be severe or entrenched behavior that is one of primary clinical concern for the team and or the family. CM in its entirety is very complex and very intensive. Standard MST itself is very effective for treating the problem area, and it's really important to be able to discern whether and when to implement the full protocol in order to achieve the best outcomes for the family. We always want our interventions to be realistic, and so sometimes if we can take a less intense approach and get a positive result, it's going to make sense to do that. So to continue with our discussion on the criteria for considering full protocol, we want to consider these factors. Is the substance use putting the youth at risk of out-of-home placement? Is substance use a strong contributor to safety risks for the youth and or the family? And substance use, is it the prioritized driver on several of the other fit factors of the referral behaviors? So a lot of our kids come to us and they are at risk for out-of-home placement. So to say that substance use is putting them at risk isn't necessarily enough to say, that's it, we've got to put the full protocol into place. We really have to look at a lot of factors. Examples of some of the safety risks that would really have us considering the full protocol are if the youth becomes suicidal or extremely aggressive with use. Drug dealers are starting to threaten the family. if the youth is pregnant, which would then pose a risk to the pregnant mother and the fetus, and the drug of choice. You know, we're not going to consider marijuana to be as intense as an opiate or something that would really put the youth at risk. Other things to consider are if the MST clinician has tried treating the youth's substance use with behavioral interventions and has not been successful, or the caregivers need supplemental help addressing the drivers of the youth's substance use. So some caregivers may need that help finding meaningful rewards or motivating the youth to stay clean. MST therapists can learn how to implement full CM protocol via an MST quarterly booster training. So whether you get that full booster training is going to have a lot to do with what your provider decides they want to take on. If we feel like in our area we're going to see an influx in youth who would warrant the full protocol, then I think it's something we really want to look at. Otherwise, we still have the opportunity to use these CM components a la carte, as in portions of it, to support what we're currently doing.